Good evening, everyone, and welcome to tonight's CPD webinar, Anticipatory Prescribing and Symptom Management for Palliative Care Patients. My name is Rebecca Taylor, and I'm the Palliative Care Project Officer at Central and Eastern Sydney PHN. I'd like to start tonight by acknowledging the traditional custodians and sovereign people across the lands on which we work. I recognise their continuing connection to land, water, and community, and pay respects to elders past and present. I'd also like to extend my respects to any Aboriginal colleagues who might be joining us tonight. I'm just going to quickly touch on the new support at home end of life pathway that came into effect in November last year. This supports individuals aged 65 years and over and 50 years and over if they are Aboriginal or Torres Strait Islander person or are homeless or at risk of homelessness who have a life expectancy of 3 months or less. These eligible participants can access funding of $25,000 over 12 weeks to support their care needs and to remain at home for longer until end of life. So the eligibility requirements for this are a medical confirmation that the individual has a life expectancy of less than 3 months and an Australian Karnofsky Performance Status score of 40 or below. So to be able to have access to this pathway, a general practitioner or nurse practitioner can refer via My Aged Care, make a referral, or through their online e-referrals at the practice. Alternatively, if you can complete the form and provide it to the patient, they can then either go to their provider if they're currently on a package, or they are able to apply through My Aged Care themselves. Alternatively, they can also call the My Aged Care number on the screen here and also visit a aged care specialist officer at Services Australia. That QR code has the access to the form that is needed to be filled out. I would now like to welcome our speaker for tonight, Dr. Hayley Worth, who is a GP and palliative care physician working in emergency medicine, complex cancer pain, and as a community medical educator in palliative care. Thank you, Hayley.
Thank you. Now, Beck, do I go ahead and reshare my screen?
Yeah.
Okay, thank you very much. Okay. Wonderful. I'm just confirming that you can see the title page there. Good evening, everyone. It's wonderful to be here with you all tonight. I appreciate that your time is precious, so thank you for joining us. Tonight, we're going to talk about anticipatory prescribing and symptom management for your palliative care patients. This is what we're going to cover tonight, and we will have a reasonable amount of time at the end for questions, so please feel free to drop any questions that you have into the Q&A box, as Rebecca said. There's no question that's too small or too big. I'm more than happy to try to answer it. And if it's a little more complex, then I can always do my best to get back to you with more information following on from tonight. Okay, so if we start off with how someone may look towards the end of their life. So they've been traveling along with their terminal illness, whatever that terminal illness may be, whether it's malignant or non-malignant. Generally speaking, in the final weeks of their disease journey, they'll be spending increasing amounts of time in their bed or chair. So this looks like a lot of sleeping time, a lot of resting time, often more than 50% of normal, so-called normal waking hours are either sleeping or resting. And of course, what goes along with that is that they're unable to attend to their personal care. So they're unable to mobilize easily to the bathroom. They often need a lot of assistance. Now, the flip side to this is that it creates a beautiful opportunity to allow for a space to be created around the bedside of that person to incorporate all of their favorite items so that while they're lying there in bed or in their recliner chair, they can be surrounded by the things and the people that are most important to them. At this stage, of course, they are much more of a passive participant in conversation rather than active participant. So they're going to be listening to the conversations going on between their loved ones. They might say a few words here and there, or they may just be completely silent and listening. Another beautiful idea in terms of atmosphere is to play their favorite music, and you can still have the favorite music on in the background while those around them are talking. So essentially the idea is to sort of continue life as one normally would while the person is there resting in their chair or in their bed. It can create a beautiful atmosphere and as they are farewelled from this life. Of course, we expect that people in this circumstance have a significantly reduced appetite. They may be interested in very small amounts of their favorite foods or their favorite beverages, such as champagne, and that is absolutely fine. If they're alert and they're interested in eating them, please go ahead and offer it to them. However, of course, we know that it's important not to push foods on people because it can be uncomfortable. They may not be interested, they may not have appetite, and it may also pose a choking risk as well. And we entirely acknowledge this can be a very culturally challenging topic. It can be very sensitive, and so we work with patients to understand that while it would be lovely to see their loved ones eat as they normally would, it's simply extraordinarily unlikely for it to be feasible in this particular context. So let's focus on what we can offer them, perhaps very, very, very small amounts of home cooked food, or just a little bit of water, a little bit of juice, and then still with life going on around them as close to normally as it normally would be. In the final days, we're seeing significant changes. So the person is becoming profoundly weak, bedbound. They're often semi-conscious or semi-comatose. At this stage, they may only be able to take sips of fluid, if at all. They are likely no longer able to take any of their oral medications because they've lost the ability, the coordination of their swallowing reflex. They're very likely doubly incontinent, so they need a lot of additional personal care. And you'll see that they're peripherally shut down. So that means that their hands and their feet are becoming cool, bluish, perhaps swollen, edematous. And that simply is the body is focusing on pushing blood to the most critical parts of the body, i.e., the organs in the central part of the body, and reducing blood flow to the less critical parts of the body, i.e., the peripheries. Of course, we know that persons at this stage of life will have changes in their breathing patterns, often with fast breathing, rapid breathing, and then slow breathing, and at times some pauses as well. And this is all completely normal. Respiratory secretions are also a normal part of the final days of one's life. Although they can sound distressing, we know now from studies that they are very rarely distressing to the person themselves. And it's more about educating the family and the carers that, in fact, this is a normal part of the end of life process. In situations where the person has a motor neuron type disease, then of course we may go ahead and treat the respiratory secretions. But usually we encourage repositioning, reassurance, perhaps gentle suctioning if it's appropriate. Now, what are the symptoms that we commonly see at the end of life, and what are the care needs that these patients have, that our patients have in this stage of their illness? So the most common symptoms that we're going to see in the last days to weeks of life are pain and shortness of breath. And this is what we attempt to address with our prescribing at the end of life, which we'll come to. Agitation and confusion are also common. And a little bit of gentle confusion may not be distressing, but if that's veering into agitation, terminal delirium, then we certainly do want to treat that. Now, of course, we know that if someone can communicate pain verbally to us, I'm in pain, I'm uncomfortable, then we know that we need to treat it. But often at this stage, we're looking at more of the non-verbal indicators of pain or discomfort. So frowning, grimacing, groaning, shifting position, rapid breathing. So you'll see in the previous slide how I had changes in breathing. And those are sort of, transient rapid breathing, transient slow breathing. But if the breathing is fairly persistently rapid, then we do need to think if that may well be a sign of discomfort. Now, often the person's carer, their loved ones, they are who know them best. So if they are concerned that their loved one is in pain or discomfort, then it's really important that we listen to that person. Bladder and bowel care are essential for the comfort of the person who is approaching end of life. We must remember to keep them clean and dry. So regular adult incontinence aid changes, regular suppositories if they're not opening their bowels. And if there's any concern that they might be retaining urine, as does happen at times at the end of life, then an indwelling catheter may be appropriate in order to relieve the discomfort of having a distended full bladder. And that's really important to consider those two aspects of their care. If we have a patient who is terminally agitated, always consider whether they're A, in urinary retention, and or B, constipated. Something that is so simple for our patients, loved ones, or carers to do is frequent mouth care. So simple and yet so important and often underemphasized. If you can imagine the feeling that you have when you've got a really bad flu or illness and your mouth is terribly coated and dry and just feels so uncomfortable, or perhaps even if you've been unfortunate enough to not have brushed your teeth for a couple of days, it's just a really, really unpleasant feeling for most of us. It's similar when someone is at the end of their life, as we really want to mitigate that sensation by keeping their mouth clean and moist. So we can do that with little sponge sticks or syringes of water, or little moistened big cotton buds, mouth sprays, all those sorts of things. And this sort of thing, really, it can't be done too frequent. It can't be done frequently enough. So the loved ones and carers who are sitting at the bedside can be encouraged to do this as often as they wish. And of course, as we said in the previous slide, offering teaspoons of fluid or food if it's appropriate, if the person is alert and indicating interest. And we absolutely have had patients whose final requests have been to have a syringe of champagne, and that is wonderful. I fully support that if that is what they wish to have. It's such a light-hearted way to enjoy your last time on this earth. Now, as the doctor or the nurse or the clinician, what are the medication adjustments that we're considering with our patients who are approaching end of life? So, of course, we have as our primary focus to the front of our minds, we have the patient's comfort. And of course, we're thinking about reducing the medication burden where possible. We can certainly stop all of the medications that are not going to improve their symptom burden here and now. So that includes things like statins, long-term mortality reducing medications that are simply not going to affect the outcome in the next few weeks to months. So stop the medications or cease the medications that are no longer necessary or helpful. If you have medications, and I'll give you a few examples shortly, that you feel are necessary and helpful, however, they are either no longer able or they're simply difficult to be taken orally, then think about changing the route or crushing them if it's appropriate. You can always check on MIMS to see if it is appropriate to crush certain medications. In terms of changing routes, there are some medications which can be given transdermally, sublingually, and of course subcutaneously, which we'll come to. So a really important example, which I always like to bring to people's attention, is for your Parkinson's disease patients, always recall the importance of continuing the Parkinson's disease medication, the anti-Parkinsonian medication, up until the very, very end of life. And that is simply by converting their levodopa carbidopa to rotigotine patch. And there are excellent and very, very simple calculators online which help you to convert to a 2 or 4 or 8 milligram, whatever's most appropriate rotigotine patch, so that person will not go into tremendous Parkinsonian rigidity in their final days when they're no longer able to safely swallow their medications. If you have patients who are experiencing seizures, perhaps it's secondary to intracerebral disease or other causes, then clonazepam drops are excellent options, even when they're no longer able to safely swallow, because it's administered into the mouth, it's absorbed sublingually, a really excellent medication option. And of course, there are some medications which one might think, oh, we can just get rid of and stop, but they may actually be very helpful to continue for as long as possible in a crushed form. And that would include your patients with end-stage heart failure. So if they're on diuretics or beta blockers, that significantly reduces their symptom load. So I strongly recommend simply crushing those medications and mixing them to thicken custard or yogurt as appropriate if they're able to safely swallow that until they're no longer able to. The same would be true if a patient were terribly depressed. It may be reasonable to crush their antidepressant and administer it that way. Now, this is where we come to thinking about which of these medications do we need to ensure that they have sufficient prescriptions for, because it may become increasingly difficult for the person and or their carers to make appointments for them. Even I know we have the luxury of telehealth nowadays, but still just thinking, how can we make this person's life somewhat easier, so to speak, and think about, providing sufficient quantities of the prescriptions that they need. Now, if someone really is approaching the end of life and they're no longer able to take their medications orally, then we need to think about the subcutaneous route for our end of life care medications a lot of the time. So we often use the term butterfly. You may be familiar with that. We talk about using a butterfly to administer medications. It's simply subcutaneous under the skin via a small cannula. So the needle and the cannula goes in, the needle comes out, and then the cannula is taped down onto the skin. And it's a generally speaking, a very comfortable way to receive medication that doesn't involve very frequent changing of the butterfly. Often they only need to change the butterfly perhaps every week or so. These subcutaneous medications uh, at the end of life may be given on a regular basis if the person is requiring them, say, for example, every 4 hours, and or they may just be required as needed or PRN, or both. And of course, we talked about giving medication sublingually or transdermally as options. You'll be familiar that some patients end up being started on what we call colloquially a syringe driver or a pump. And this is simply a continuous subcutaneous infusion. It runs 24 hours a day, 7 days a week, and it allows for very, very slow, continuous administration for medicine, which really gives, ideally, incredibly controlled, incredibly well titrated control of the patient's symptoms. And then on top of the syringe drive or a pump, we can still give additional PRN doses if needed. So say if the person is being washed in bed or changed in bed, they may require, or having wound care or something like that, they may require an additional PRN before that. Or it may simply be that their pain needs are increasing. They may then require additional PRNs on top of the pump. It's just a beautiful way of having the medication administered so that the family doesn't need to worry about administering the subcut medication every 4 hours. And then, of course, the community nurses come along every morning or every day and change the pump and make sure that the correct dose of medication is running. Sometimes it can be a 48-hour pump as well. Our community nurses are absolutely integral in providing family and loved ones with education around how to actually administer these end-of-life subcutaneous medications. So what they'll often do is they'll have the ampules, they'll draw them up into syringes, label the syringes, explain with very clear detail and very clear instruction what each medication is for, how often to give, along with written instructions. And then the family feel comfortable and confident in administering those subcutaneous medications until, say, the next day or, a couple of days when the nurse comes back and visits and checks on how everything is going. There is always the elephant in the room, which I must address around opioids being administered at the end of life. I understand some of you may have had experiences where perhaps you've been on a ward and a certain this may be decades ago, but perhaps someone has said, "Oh, look, let's bump up the morphine and we'll make Mrs. Smith's suffering end sooner." I want to assure you that with modern day specialist palliative care, there is no evidence that appropriately prescribed opioids hasten the dying process. We are neither seeking to hasten nor prolong the dying process. We are simply seeking to ease the discomfort that may be associated with the dying process. Now, many of you will be familiar already with how to refer to your local community palliative care teams, but I thought it just might be helpful to briefly go over this. As you likely well know, our community palliative care teams across the public health, across the CESPIN network, are very much multidisciplinary. So they incorporate medical, doctors, nurses, physios, occupational therapists, social workers, and more. And every single one of those team members are absolutely valuable because, of course, it's the physios and the OTs who provide the equipment and support them to be able to stay at home support the person to be able to stay at home for as long as possible. It's the nurses who provide all the education and really cold-face support. It's the social workers who assist with things like the aged care packages and so forth. Now, CPCT is what we sort of call it in short, community palliative care teams, or CPCT, are really intended quite specifically to support patients in the last days, weeks, to perhaps months of life. If the person is well enough to be taken to a clinic at the hospital, then that is where they're normally seen leading up to the final phase of their illness. They are normally known to a palliative or supportive care clinic before they're linked in with the CPCT, but not always. Sometimes they've had such a rapid deterioration that they haven't had a chance to be linked in with the hospital palliative or supportive care clinic yet. So if they are already known to the relevant palliative or supportive care clinic, then often as they're seen to be deteriorating and as it's seen to be, okay, unfortunately, Mr. Smith is no longer able to come in and see us at clinic anymore, then it may be the palliative care clinic who refers the person on to CPCT and says, Mr. Smith is becoming increasingly frail. Are you able to visit him at home in the next few weeks and check in on how he's going? But if it is one of those situations where they've deteriorated so rapidly and sort of it's all happening here and now, then the GP absolutely can refer directly to CPCT. And I've put I've put several of the different referral options there, depending on what your most local hospital is. Calvary, Prince of Wales, Vinnie's, and up here. I apologise that I couldn't find the details for Concord, but I imagine that everyone is far more adept than me at finding these details. I would really highly recommend that if it's an urgent situation where you think this person really needs to be seen within the next few days, that you actually phone the number, and if you're able to get through, speak to someone like the palliative care CNC and emphasize the urgency of the referral. And if need be, if you're not having any luck getting through on the phone number, then actually phone and speak with the on-call palliative care physician so that they can escalate it. Because it may be that sometimes some of these some of the hospital CPCTs are really have a tremendously high patient load. So you may need to bring it to their attention if someone is particularly urgent. Otherwise, it may not be for a couple of weeks that someone goes out to see them. Rebecca mentioned the support at home end of life pathway, which is really excellent for our patients who are in the last 3 months of life. It is a bit of a shame that it's only really for our older persons. I think it would be great if they extended to everyone. However, that is what we have available to us at the moment. So it is great if you can use it for your older patients. That's wonderful. Okay, and now we're going to move on to the second part of our presentation, which is all about anticipatory prescribing. And to some of you, this may come as a bit of a surprise because you may consider that the role of prescribing end-of-life care medications is solely or primarily up to the palliative care team. However, we'd like to propose that it may, in some cases, it may indeed be completely appropriate for GPs who know their patients very, very well and often have quite close contact with their patients and the patient's carers and loved ones to prescribe injectable end-of-life medications. And essentially, the role of anticipatory prescribing is to prescribe the medications prior to the patient actually requiring them. So it's essentially in anticipation of the symptoms emerging as they approach the terminal phase of illness. And that's why at times it can be the GP who says, oh, Mr. Smith was able to come into clinic last time and now his wife has come in or has phoned me saying he's now not able to get out of bed. Oh, okay, things are changed for Mr. Smith. Perhaps I should be thinking about anticipatory prescribing. And so what are the tremendous benefits of anticipatory prescribing? Well, they are twofold. They allow for early management of symptoms, which then avoids a symptom crisis. So if our patient doesn't have any appropriate, for example, pain medicines at home, and their pain is evolving, increasing, they can end up in a terrible pain crisis that can then be very challenging to get on top of. It also, secondly, provides for continued care at home and thus avoiding undesired hospital transfers. A lot of our patients do not want to end up in ED, and really we don't want them to be in ED either. ED is a vastly unpleasant place to be at the best of times, especially in the days of bed block where, they may be in ED for 24 hours or more waiting for a bed. At times they'll be put in the waiting room, not even on a bed. So of course there are times when ED is eminently appropriate. But if it's appropriate and if it's possible to avoid ED, then that's wonderful. Now, as Rebecca mentioned, one of my roles is in emergency medicine. I do work for New South Wales Ambulance, and I can absolutely assure you that if paramedics arrive at home and there are medications prescribed for the person appropriately, for the palliative care patient appropriately at home, then they then have the ability to call a doctor such as myself and explain the situation and liaise with us as to commencing or administering those medications. It opens up so many more options for the person who's at home, who's wishing to stay at home. So it really is a wonderful option, and it's sort of a little bit of stepping just outside your comfort zone. But I would encourage you to consider that. And if I can give you a few parameters here to allow you to feel like you're doing this safely, then perhaps you'll consider this in the following situations. So if you, from your assessment, and none of us have a crystal ball, none of us know for certain, but if you suspect that a patient is approaching the terminal phase of their illness, for example, a rapid change in function, Karnofsky score of 40 or below, reducing ability to swallow, and perhaps they know they're dying, perhaps their loved one, their partner or their child says to you that they're concerned that they're dying, then I'd really strongly consider I'd really strongly recommend considering it. If eh, Also, if the person has limited access to the community palliative care team, so perhaps they're linked in, or perhaps they're awaiting link in, but there's just sort of sporadic visits, and perhaps their next visit isn't until next week, then you may consider, okay, this is appropriate because now we're ahead of the ball just in case they need them. And or if they've got limited access to their pharmacy, because remember, a lot of pharmacies are not open 7 days per week, or perhaps the patient can't even get there. And some medications have to be ordered in. They might take 24 hours or more to get in. So thinking about if I do prescribe these medications, it may take a good day or two for the patient to be able to access them anyway. And or if they have limited access to yourself, their GP, it may be appropriate. And I say that in the most respectful way possible because I know how busy GPs are. And it may be that simply, let's say if the person is in dire straits in 2 days' time, they may simply not be able to make an appointment with their GP. They may end up needing to go to ED simply out of necessity. And we can all understand those situations completely. It's just nice if we can have a way of working around them. Of course, the person would have a specified desire for end of life care at home. So if they say to you, oh, if you say, okay, what are you going to do if your pain becomes really bad? And they say, oh, I'll just go to ED, then that's not the sort of person you're going to be considering anticipatory prescribing for. But if they say, I want to stay at home for as long as possible, or even I want to die at home, I want to be cared for at home until the very end of my life, those are the patients who you absolutely would benefit from considering anticipatory prescribing. Of course, and this is an absolute must, we must have carer and or family who are willing and able to administer subcut medications. And that has to be someone who's willing to be there around the clock, 24/7, even if they're taking turns or they're on a roster or something like that. Because as well-meaning as someone is, if they say, oh, no, 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 I could never do that to my dad, I could never give those medications to my dad, then there's going to be likely no benefit to prescribing anticipatory medications, and it will likely require a conversation that sort of realigns the goals of care and say, look, I understand you would like to stay at home for as long as possible. However, at the moment, your daughter is saying that she doesn't feel comfortable giving you these medications. So the better place for you to be would be in hospital. Now, when we're prescribing anticipatory medications for end of life, of course, the patient absolutely should be either linked in with or referred to the CPCT. So even if they're still awaiting their first visit or awaiting their first appointment, that's okay. As long as the referral is in place, then that's excellent because, of course, that you need to have the community nurse to come along and give the education and so forth. But the benefit of anticipatory prescribing is that you, as I said, you're already ahead of the game, you're ahead of the 8 ball, the medications are there in the house, and then if a crisis unfolds or if symptoms worsen and they need those medications, the community nurses can come in fairly promptly and teach the patient's loved ones to administer the medications. Or worst case scenario, the paramedics can come and assist with administering them. But if the if the medications are not in the home and the nurses are called, then the nurses need to be able to access a doctor to prescribe the medications, and that's often not something that's very easily done. That may take a couple of days to allow for a doctor to then give approval for those medications, because as we all know, generally speaking, doctors have, well, no, I better not say that. It might come up. I was going to say doctors have somewhat more limited time. It's not quite that. It's just that they're sort of juggling different roles. Um, okay. Now, if we've looked at all of these parameters and we think, okay, this person is appropriate for me to consider anticipatory prescribing, then these are the principles by which we're going to abide. So we're going to consider the total daily background opioid usage. So I've got an example here where Mrs. Smith is taking MS Contin 30 milligrams BD. That's a pretty average dose, really. It's not super high for someone who has an end stage disease of some sort. Now you're going to take the total daily background opioid dose. You're going to divide it by 2 to get the total daily subcut dose, then divide by 6 once again to get the 4th hourly dose as well as the PRN dose. So in Mrs. Smith's case, his total oral daily dose is 60 milligrams, which is equivalent to 30 milligrams subcut daily, or divided by 6, 5 milligrams subcut, 4th hourly, as well as 5 milligrams 2nd hourly PRN. So it's not too difficult to convert someone to the equivalent of in terms of subcut medication. However, I strongly recommend if there's any sort of complexity involved whatsoever, and especially if you're rotating opioids. So say, for example, they're on OxyContin, or another medication that you need to get them off and get them onto morphine or something like that. Absolutely use an opioid calculator. In fact, I would strongly recommend that. So EviQ Palliameds is an app. EviQ has an excellent calculator. Use those to safely assist with calculating your dose, and you can be absolutely assured that those are very conservative calculators, and in fact, they incorporate into their calculation a dose reduction. So my next point there is to do a 30% dose reduction when you're rotating opioids. But those calculators will already incorporate a minimum 30% dose reduction. So they're very, very cautious. Now, if you are rotating a person, your patient, especially from Targin, which can, especially towards the end of life, be suboptimally or partially absorbed, then absolutely ensure that you've incorporated dose reduction. Remember, you can always go up. If you start someone on their subcut medication and it's they're always going to have PRNs available, and you can always go up and increase the dose, or the palliative care team can advise on increasing the dose when they're reviewed. If the person is already on an opioid patch, so if they're on background fentanyl or background Norspan, we strongly recommend not removing the patch because that will muddy the waters. It takes about 24 hours to the dose for the patch to sort of come out of the system. And in that period of time, it's hard to know sort of what's working and what's not working, and they can end up in a lot of pain. So simply continue the patch, either every 3 days if it's fentanyl, or every week if it's Norspan. Continue the patch and add on a PRN opioid, whether that's morphine or hydromorphine, whatever is appropriate, at a dose of 1/6 the total daily background dose. So again, use an opioid calculator to help you if you're not sure. And if you're in a situation where you've got a person who's on a very complex medication regimen, for example, the one that comes to mind is methadone. Methadone is highly complex. If you at all feel unsure, uncomfortable, pick up the phone, call your friendly local on-call palliative care physician, say, I've got a person who's deteriorating. I want to prescribe them some anticipatory medications. This is a regimen. What would you recommend that I prescribe that would be safe whilst they're awaiting community palliative care visit? And that's totally okay to do that because we understand that these are not medications that you're dealing with every day. We absolutely understand that there can be a degree of discomfort with them. Now, if you have a person who's not on any background opioids, so you're prescribing them essentially de novo, I've written out for you here the exact regimen which I would recommend. So there are the doses here for morphine, hydromorphone, metoclopramide, and midazolam. So morphine and hydromorphone are both for pain and dyspnea, breathlessness. Metoclopramide is for nausea or vomiting. Midazolam is for agitation. Now, of course, there are other medication options as well, but these are just the simple ones to consider as if you're prescribing anticipatory medications. Just this, if you're starting with the three M's, morphine, metoclopramide, midazolam, then you are doing an absolute world of good. The quantities that are written there provide sufficient to last the person around 48 to 72 hours, which really is excellent because it provides them with, if they do enter a crisis, a symptom crisis, then it provides enough time to spare until the community palliative care team can refer them. I beg your pardon, can review them. As a courtesy, I do think it's good practice just to phone your local pharmacy, whichever pharmacy they're going to, just advise them, say, look, I've prescribed Mr. Smith some anticipatory medications for end of life, so his wife is going to come in. Do they need to be ordered in? Oh, yes, okay, that's fine, wonderful, thank you very much. Just as a courtesy to let them know, because it won't be every day they're dealing with these medications either. Now I've put there in asterisks kidney failure for sorry, I beg your pardon, hydromorphone for kidney failure. It's really, really important that if you have a patient who has either chronic kidney disease or end-stage kidney disease, instead of starting them on morphine, do start them on hydromorphone. The reason for that is because the toxic metabolites of morphine are excreted in the kidney. So if the person's kidneys are not functioning well, then the toxic metabolites will build up in the bloodstream and they're not able to be excreted by the kidney, and the person feels absolutely rubbish and their pain is not relieved. So it's not because we're worried that the morphine is going to damage their kidneys, it's because we're worried that the morphine is going to A, not work, and B, make them feel rubbish. So always remember that for your patients with end-stage kidney disease or chronic kidney disease. And another slide that I'm more than happy for you to screenshot, just to simply refer to as a little bit of a cheat sheet for your patients who are at the end of life. These are the medications that are essentially just a very short list that you consider according to symptoms. So for pain, I've got there morphine, hydromorphone, oxycodone, methadone. We would never ever be expecting a GP to be prescribing methadone. However, it's simply something for you to be familiar with, and then the palliative care team would be the ones who'd be advising it or prescribing it. Of course, fentanyl as a patch or Norspan as a patch can be very helpful. For breathlessness, always consider a small handheld fan aimed directly to the face. Oxygen, if appropriate, like if their saturations are less than 90 to 92%, if it's appropriate. Morphine, hydromorphone have been shown to be effective for breathlessness, and often we need lower doses than for pain. But just to keep it simple, there I've kept the dose the same for morphine and hydromorphone for both pain and dyspnea. If you want to keep it simple, that's absolutely fine. For terminal agitation or distress, midazolam, haloperidol, most commonly used ones. Please don't use haloperidol in Parkinson's disease, however, as it can increase Parkinsonism. And sublingually, of course, you can do clonazepam liquid, which is excellent. Olanzapine wafers are another option as well. Nausea and vomiting, of course, we know about metoclopramide, haloperidol. Neither metoclopramide nor haloperidol should be used in Parkinson's disease. There's also the option of cyclizine, a little bit less common, but it can be very effective. And then I've got there, if you might consider olanzapine and ondansetron also for nausea and vomiting, although we don't use ondansetron a lot for our palliative care patients, but you can consider it if the others are contraindicated. We're always remembering our bowel care, so we're remembering our suppositories. I do have there a little blurb on respiratory secretions. As I said, they're generally far more distressing to those around than they are to the patient themselves. However, if you do feel very strongly that you wish to have something available, then glycopyrrolate or hyoscine, just in teeny, teeny, tiny doses. If we know that if we use uh, the the sorts of doses that we used to use in glycopyrrolate, like 400 micrograms 6th hourly, they tend to dry out the patient's mucous membranes and actually worsen agitation. That's why we've really steered away from it recently. And of course, for seizures, we can consider midazolam, Keppra infusions, and as I've said, they're clonazepam. Clonazepam is really a wonderful medication. It's very, very helpful and easy to administer for the family. Okay, so I'm going to open it up to the floor now. We've got plenty of time for questions.
I guess, Haley, I'm pretty sure I'm not sure if you mentioned it, but for the secretions, I know before when you've spoken, for someone with, is it Parkinson's or
Yes, or motor
um,
neuron disease.
neuron disease, you recommend?
So that's a very specific situation. Especially in our LHC, we're really lucky to have a wonderful motor neuron disease clinic at Calvary Hospital and St. George, which is run by Frank Brennan, as many of you will be aware. And they do have a lot of tips and tricks up their sleeve for patients, because for patients with motor neuron disease in particular, because their secretions are often categorized in two different subtypes. They may be those thick, tenacious secretions which need the sort of mucolytic type agents, or they may be the incredibly copious, watery secretions where they're literally going through 3 tissue boxes a day, just like producing copious secretions. And that's when we would use the drying agents. So I just want to be clear, there is certainly a role for drying agents. We've just got to be cautious about the time and place that we're using them. And if you've got a patient whose family or whose carers are tremendously distressed by their secretions, I understand that. I'm always open to compromise, and it may be that considering a teeny tiny baby dose of glycopyrrolate, occasionally is what is sufficient to ease the loved one's sort of concern for their family. But just to also remind them, like continuing to remind them, it's actually similar to sort of slurping through a straw if you're drinking a smoothie. It's really not distressing to the person. It just sounds like it's that terrible sort of rattly, gurgly sound. Repositioning can be very helpful. And if it's appropriate, like if it's a nursing home, they may have gentle suction available just for the oropharynx, of course, not going further back than the oropharynx.
So in the Karnofsky scale, do you?
Oh, I beg your pardon. I
Mhm.
should have had a little diagram. Okay, so all of us here about essentially. Let me go back. The Karnofsky score is from 0 to 100. 100 is all of us here, or perhaps we're 90% because some of us are a bit tired at the end of the day. But generally speaking, we're all able to participate reasonably fully in in our activities of daily living. So we're all probably sitting around 90 to 100%. Now, someone who's dead is 0%. Someone who's passed away is 0%. Someone who's very much terminal is 10%. So if you go halfway between, 50% is someone who's spending more than 50% of their daily waking hours in a bed or a chair. So that's the magic number to look for. When someone is slowly reducing in their function and they hit that magic number of 50%, where they're spending at least 50%, at least half of their waking hours in bed or chair, then we're really going to start seeing the decline downhill. Because studies show that, unfortunately, once we lose that sort of function, it's very unlikely we're going to get it back. And then, of course, 40%, 30%, 20% is just a slow and gradual decline where they're becoming increasingly dependent and increasingly less mobile. I hope that answers the question. 10 and 20% is more or less comatose in bed all the time.
Thanks, Haley. There's another question here. So, in a home environment, is there a minimum kit of anticipatory medications and equipment people should have available?
That is excellent. And that is why I would refer to that slide. That's my cheat sheet for you. That is the quantity that I'd be suggesting. That would be the minimum. And really that's a good quantity because it will provide them with a couple of days, 2 or 3 days supply. So essentially, if this is your patient who you're prescribing, sort of they haven't been on background opiates before, this is what I'd recommend. But if they've been on whopping doses of background opioids, obviously that morphine dose that I've prescribed there is not going to be sufficient. So they're going to need a substantially larger supply of morphine or hydromorphone equivalent ampules. And then in terms of the other supplies that they require, like, all the syringes and butterflies and alco wipes and saline flushes and so forth, that's all supplied by community nursing. It's only the medications that you need to provide. And in my experience, a lot of the time these medications are not even used, but it's tremendously reassuring for the family to know that they are there if they do need to be used. And again, in my experience, I'm yet to have anyone abuse this. Of course, you're not going to be giving it to someone who you know is, a well-known drug misuser. But in my experience, I'm yet to have someone abuse in these particular situations, and they're generally extremely cautious, and they keep them, locked up away in their medicine cabinet and away from, little kids who happen to be in the household and things like that. So I've found it to be an excellent way of sort of bridging the gap, if you will, between the time when you know that they're deteriorating and when community palliative care can come on board.
Okay. So that question has been clarified
Yes,
around the CPR.
yes,
So it says, so if there's a palliative care patient and the doctor has ordered a not for resus, how
yes.
long is that not for resus legally
Oh, what
effective?
an excellent question. Um, So I'm just going to break this up into a couple of different sections. If the patient themselves have completed an advanced care directive, that's a legally binding advanced care directive, as per the New South Wales form, that is indefinitely legally valid. So essentially, it does not have an expiry. It does not expire unless, of course, if at any stage the person themselves wishes to change it, they are well within their right to do so. Now, if a doctor completes an advanced care form, like a ceilings of care form or a resuscitation plan that specifies that the person is not for CPR, then that's usually only valid for each admission. And then each admission that the person comes into hospital, just as a matter of courtesy, it's revisited. Even if we all know that the person is still, like, we're not going to go ahead and suddenly change and decide that this person is actually now appropriate for CPR, it's still respectful and courteous of the person to have that discussion with them and or their family members.
Okay. So there's someone's written in. So my patient is on palliative care for end-stage renal failure,
Yes.
but is still teaching her beloved music students and is on
Oh.
long-standing sertraline, recent Norspan 5 milligram patch, and naloxone TDS orally. So the pharmacist has flagged a risk of interaction between the sertraline and Maxilon, not
Maxilon, thank
Maxilon,
you.
sorry.
Thank you.
Um, and then in brackets it says cyclizine prescribed if Maxilon ineffective. Is this something we need to be cautious about?
I can understand why they're considering that maybe there's a slight risk of serotonin toxicity, but I wouldn't be concerned if she's not showing any symptoms of interaction. I wouldn't be concerned. We combine those medications fairly readily. I have to admit that in palliative care we have a reasonably sort of higher threshold for concern when we're combining I beg your pardon, combining medications. And of course, if the person is displaying or describing symptoms, then we should consider whether polypharmacy is at play. But otherwise, we tend to have a much higher sort of threshold for risk. And how wonderful that they're continuing to teach
Mhm.
music. That's such a heartwarming story. Thank you for sharing it.
Okay, and there's another one. So, what happens if a patient wants to die at home, but the family is unable to cope with the dying process of the patient, or
Yeah,
the family is unable to give medications? When
yeah,
is the discussion for hospice care?
yeah. Look, it's a very sad situation, and we all greatly empathize with those situations. However, they simply cannot be cared for at home if they do not have family members who are willing to be on board with that, or family members or carers who are willing to be on board with that. So be trying to reach a middle ground, and that is when the palliative care unit, the hospice, would likely be a very appropriate middle ground. And yeah, I mean, we've all encountered those situations, and you feel so sorry for them because all they want to do is be in their own home, their own environment, their own space, at the end of their life. But we simply cannot always accommodate that, unfortunately. If it takes a tremendous amount of resources, a tremendous contribution on the family's part or the carer's part to care for someone at the end of life.
Okay. I just sort of quickly, Hayley, I might just quickly touch on again for anyone who joined late around the new support at home end of life pathway, just so that you're all aware. So from November last year, through the support at home program, there's a new end of life pathway which will enable individuals of 65 years and over and 55 years and above for Aboriginal and Torres Strait Islander persons or homeless or risk of homelessness, with a life expectancy of 3 months or less to be eligible for funding of $25,000, which will help to support their care needs so they can remain at home during end of life. But to be eligible or to be referred to this pathway, a medical practitioner or nurse practitioner will need to refer the patient. So they can do this via My Aged Care, make a referral, or they can complete the form, which we'll send to you after this webinar, and that will be that can be given to the patient, and they can either give it to their current provider if they're already on a package, or it can be they can refer themselves through My Aged Care portal. Sorry, Hayley, we do have one more question. So
Yes.
if a family reports rapid symptom change, when should they call the GP versus community
Mhm.
specialist, palliative
Mhm.
care versus emergency services, noting the difference in services availability in hours versus other?
Oh, look, that's an excellent question. It somewhat depends um on where they are at in terms of the sort of terminal slash dying process. If it's reasonably early on and they're not yet very closely linked in with community palliative care, then GP is probably more appropriate because they may not yet have that very ready access to community palliative care. So it may be that they're still waiting on seeing community palliative care and they're not able to see them until next week or even a fortnight or more away. And in which case, having a telehealth or going in to see the GP may be more appropriate. Um, Generally speaking, once they are linked in with community palliative care, they're given a 24-hour phone number, which they're encouraged to call at any time of the day or night if they're in a lot of discomfort or distress. And they're encouraged to put that phone number on the fridge so that they can see it and call it. But sometimes what will happen is that they call that phone number and either they're busy, like they're unfortunately unable to assist, or they're actually the nurse on the other end is actually simply unable to provide assistance because perhaps it's the middle of the night and the person simply doesn't have the medications um, available to be given to them, and that is when it may be appropriate for them to call 000, and that is a lot when a lot of our 000 calls come in. It's the middle of the night, they're in horrendous distress and they've tried calling the 24-hour number and they're simply not able to get, and it's through no one's fault, of course, they're simply not able to get the support or the answer the help that they require. And then if they've got those medications at home, then our paramedics can go along, attend the scene, and we can advise on giving those medications.
Thanks, Hayley. I'd like to thank everyone for attending tonight, and especially to you, Hayley, for presenting. It's been
My
really
pleasure.
insightful and great information there. So just a reminder to please complete the online survey that will pop up on your web browser, and as well as a post-training survey that will be emailed out to you following this session. We hope to see you all again soon. Thank you.
Thank you.